So let's get started. This is another presentation today where we will be uh, discussing within the context of the approaches and interventions in pre-elimination, elimination, and prevention of reestablishment of malaria in the African leadership and management training for impacting malaria eradication. And my name is Dr. Lwidiko Edward Mhamilawa, and I am with the Department of Parasitology and Medical Entomology at the University of Muhimbili. And I will be talking to you today about malaria case management. And among the learning outcomes within the context of malaria case management today is to help you understand issues related to how do we define a malaria case definition, issues associated with being aware of the guidelines towards malaria diagnosis and treatment, and also looking at priority actions that are required when it comes to quality assurance in the diagnostics and also in the anti-malarial drugs. And finally, we would like to make you aware of the programming and then when it comes to monitoring and evaluation of efficacy and safety of anti-malarial drugs and anti-malarial resistance. So my presentation will have several instances where we'll do the introduction, case definition, we'll talk about diagnosis in length, we'll talk about treatment in length, and we'll talk about the monitoring of efficacy and safety anti-malarial and the drug resistance, and also have some references and reading materials. So as an introduction, the core principles that are related to malaria case management involve these 4 items. 1, make sure there's an early diagnosis and prompt effective treatment. And these both go hand in hand when it comes to making sure the diagnosis is early, within 24 to 48 hours, and then prompt effective treatment. This is something that needs to happen almost immediately after the diagnosis is found, and the treatment has to be effective. These are keywords that we're going to carry over along the lines. And also, don't forget that you have to be a rational use of anti-malarial agents, meaning you administer to only those who truly have malaria. Not every fever is malaria, so there's a huge component of diagnostics there. And then when it comes to medication, there is always a use of combination therapy. So no monotherapy that is allowed. So you have to use at least 2 effective anti-malarial medicines with different mechanisms of actions. We're going to discuss this a little bit when it comes to the medication treatment. And also you have to make sure that the dose that you give is age, or rather mostly weight-based dosing, where you can attain effective concentration of the anti-malarial drugs in order to maximize the likelihood of a rapid clinical and parasitological cure. So these are the 4 principles that we'll be discussing and going up and about across the board every time we discuss issues associated to malaria case management. And for those who have seen diagram like this before, shouldn't worry about it, but mostly I want to orient you around areas where malaria can be prevented or treated and malaria drug use can be used within the discussion of the malaria life cycle. So the first part is where the parasite is being injected into the human body through the sporozoites, where the mosquito injects the sporozoites. They're usually few in number, and there's an incubation period between the parasites coming from the mosquito, and they go to the liver and they start to incubate there to manifest. And depending on the species, it might take up to 5 to 7 days sometimes for these sporozoites to mature to become merozoites that are ready to attack the circulation. And this is a place where you could use medications that will prevent development of a disease, which is known as prophylaxis or causal prophylaxis. This is a pre-erythrocytic stage. And then after that, the parasites mature as merozoites. They enter the blood cycle, which is the erythrocytic cycle. This is where you get clinical malaria. And the red blood cells are the ones that are primarily infected, and they would rupture and will release some cytokines that would trigger some inflammatory responses, where you have a typical fever that you see. And depending on the site or the parasite that is infecting you, you could have tertian fever, quartan fever, fever that is episodic every 12 hours, or it could be another type of fever. We'll see that in different parasites that we're going to see shortly. And after a while, the parasite is going to convert into the gametocytes, which is a transmission phase. And then this transmission phase, the mosquito picks it up again, continues the life cycle in the mosquito side. I'll not focus on the mosquito side today. Now, this one last point I'd like to point out before I move from this diagram is the incubation period has some medication that can be used to prevent the establishment of a disease, but this is prophylaxis. Clinical malaria, this is where someone is sick, and then the medication to treat the sick person. And then the gametocyte stage, this is where if you kill these gametocytes, you prevent the ongoing transmission of this parasite. So I will refer to this life cycle also as we go on. Now, there are several different species of Plasmodium which causes malaria to human. And there are like 5 species that you can see there in this table. And all these species affect humans at different stages and have different properties. The one that affects mostly humans and is much more severe is the Plasmodium falciparum parasite, which is has a pre-erythrocytic stage of up to 5 to 7 days. And before it starts to cause the havoc in your red blood cell circulation, which happens within up to 14 days, the erythrocytic cycle can continue until you die if you're not treated, and usually affects all red blood cells, irrespective whether they are young or they are matured or they're reticulocytes. And then they usually can go as parasitemia can go as high as 2 million parasites per microliter when it comes to severe malaria cases. And you could have paroxysms, and that are like lasting between 16 and 36 hours, which is not very, or even longer paroxysms, and it has a higher risk of severe malaria, but usually does not have relapsing forms of the disease because it has no hypnozoite that will retain in the liver for a long time. And you could have recurrent of the infection, but this would be mainly due to treatment failure. The other one that is also known for causing severe malaria is Plasmodium nosai. This is primarily a parasite of the macaque monkeys. So it's monkeys to human transmission. Human to human transmission is still being investigated. And this is a parasite that also can cause severe malaria, but it's a very rare cases and is not very common in African, sub-Saharan African setting. Other species like Malaria, Ovala, and Vivax, these are known to cause less severe form of malaria, apart from Vivax, which is relatively minimal compared to Plasmodium falciparum. But another major difference is existence of hypnozoites in other species than the rest. So most of the examples that we'll be discussing moving on will be around the Plasmodium falciparum species. So when it comes to case definition of the malaria, there are 2 aspects that I've brought into attention right now. So one is whether it is epidemiological case definition or it is clinical case definition. Are you looking at it from a clinical utility or from an epidemiological utility? From a clinical utility, this means it's an occurrence of malaria illness in a person whose presence of malaria parasite has been confirmed by parasitological testing. So this is symptomatic person who has illness or the disease. This is where you could define a malaria case, but it has to be confirmed by parasitological testing. In another case where you're looking at epidemiological utility is where someone has the parasites inside their blood when it is confirmed by parasitological testing, irrespective of whether or not they have symptoms. And these would be the asymptomatic or symptomatic cases where they're both considered as malaria cases. And this will be important when we're discussing in malaria control and elimination and pre-elimination settings. Asymptomatic cases will be much more relevant. But symptomatic malaria can also be subdivided into uncomplicated malaria and into severe malaria or complicated malaria. Uncomplicated malaria is a person who presents with normal symptoms of malaria, such as fever, chills, sweat, headaches, muscle pain, nausea, and vomiting, but they have no features of severe malaria, and they have been diagnosed to be parasitologically positive by a microscopy or a rapid diagnostic test. And severe malaria would have features of an uncomplicated malaria, but in addition to that, they would have additional symptoms such as impaired consciousness, which is for adults who have a Glasgow coma scale of less than 11, and for Blantyre coma scales, less than 8. And a person will have prostration, be too tired all the time, multiple convulsions, more than 2 convulsions within 24 hours. This is important because when you're talking about severe malaria or malaria generally in children, especially under the age of 5, they tend to also have febrile convulsions. So sometimes the malaria, the convulsion could be due to the fever and not necessarily due to the cerebral or malaria. So the definition is here to have at least to carefully monitor any patient who has a convulsion, but at least multiple convulsions within 24 hours. And hypoglycemia is another sign, and then acidosis, where a person has tachypnea, severe malaria anemia, renal impairment. This is also due to attacks of the parasites into the kidney tissues. And jaundice is also another prominent feature that is indicative of an increasing red blood cells rupture, hemolytic rupture, and causing to yellowish discoloration of the eyes, and then can go to respiratory distress, which is secondary to pulmonary edema. Then you can have some significant bleeding, shock, and if you have hyperparasitemia of more than 10%. This is 10%, more than 10% of red blood cells are infected by the Plasmodium falciparum. And the case can be classified also sometimes as suspected, presumed, confirmed, autochthonous, indigenous, induced, introduced, imported. All these are other definitions of cases when it comes to looking at alternative definitions when you're talking about epidemiological definitions of these cases. So when it comes to malaria diagnosis, malaria is suspected clinically primarily on the basis of the fever or history of fever. So, but then there is no combination of any signs and symptoms of that can reliably distinguish between malaria from just other causes of fever, whether viral causes or bacterial causes. And diagnosis that is based on only clinical features has very, very low specificity and usually can lead to over-treatment. So always conduct parasitological tests within less than 2 hours and patient arrives at the health facility and then offer them treatment. So suspected malaria in endemic setting, this is when you want to suspect malaria in endemic setting, it's when any patient that has presented with fever, history of fever, and that has no any other cause, you suspect malaria, and then you go with this treatment, test and treatment. And then if it is within stable transmission setting, where there's a high seasonal or there's high seasonal transmission, you look at every child who has like palmapala or hemoglobin concentration of less than 9, you have to suspect that this person may have malaria, and then you test, and if they're positive, you treat them. And then in low transmission setting, where malaria is very, very uncommon, people who have recent history of traveling to malaria endemic settings without protective measures and they have fever, you can have high index of suspicion of malaria. And now, but then in cases where the patient is suspected to have severe malaria, but it belongs to high risk groups. So let's say patient has HIV or AIDS and also immunocompromised, and it comes to your setting and there is a delay in getting a parasitological diagnosis, whether you don't have a microscope or you don't have rapid diagnostic test, you should not delay the treatment for this patient. Start treatment and then continue with the parasitological confirmations, because these patients, as you will see later on in treatment, they are at high risk of developing severe malaria. Still on the diagnosis, now we're going to break down a little bit when it comes to this three major tools that we can use for malaria diagnosis, as microscopy and rapid diagnostic test and nucleic acid amplification test. Microscopy, you visualize the test under a microscope from the peripheral blood, and then you detect whether or not the parasites are there. In rapid diagnostic test, however, you detect the presence of parasite antigens. Excuse me. Using lateral flow chromatography tests. And using nucleic acid amplification tests, you're looking at molecular detection of parasite DNA when it comes to using these things like a polymerase chain reaction or loop-mediated isothermal amplification. These are some of the tools. Now, there is a difference when it comes to sensitivity of these tools, right? So this graph here shows you the parasite detection ranges of different diagnostic tools and their limits when it comes to performance. And here is a parasite per microliter of blood, and this is how long it can be still positive. So you can see here the limit of detection for rapid diagnostic tests and field microscopy, is between 100 to 150 microliters or less. But then these other ones, which are molecular detection tools, can go as low as 10 or less. One, sometimes ultra-sensitive, can be even 0.1 parasites per microliter can be detected. And these have different utilities when it comes to field testing or in clinical use of these tests. So you would now to think about the questions of what are the limitations, and this graph, this table here, I'll guide you through it on to look at at what point are these tests even more relevant. So when it comes, if your criteria you want to look for parasite density, the microscope is the best tool for you to use, and this is because it helps you to be able to quantify. And why is parasite density is relevant? Especially when it comes to follow-up of admitted patients. You have an admitted patient, they have a high parasite density, and then you want to follow up whether or not the parasite density is getting lower, or they come back with new symptoms, and you want to see that they have parasites or not. But when it comes to uncomplicated malaria cases, you can use either rapid diagnostic tests or microscopy, because these are target cases and what clinical setting you're looking at. In severe cases, when you're admitting the patients, you can use a rapid diagnostic test, but not alone. You have to complement yourself with the microscopy to be able to differentiate species and things like that. But when it comes to looking at antigen presence can be detected only in rapid diagnostic tests, while microscopes do not test the antigen presence. Now, how is this going to be useful when it comes to clinical setting? In confirmed malaria cases, where you have persisting fever despite malaria treatment, then you can't use a rapid diagnostic test, because you will only get a positive test. Again, you'll see in a moment that this parasite will still be indicated as positive because it's measuring the antigen. But then you will need a microscope to be able to identify whether or not there are parasites you can see. And when you're looking at cases that are persisting fever, but they were not previously tested for malaria, then rapid diagnostic test can help you know that this person has been exposed to the parasites or not, and both can be easily usable. And when you talk about consisting of cases where fever is ongoing and patients did not receive any malaria treatment, microscopy can be a useful tool. And when it comes to use electricity supply that's needed, you don't need electricity when it comes to rapid diagnostic tests. And for microscopy, usually requires reliable electric supply, but some microscopes that use only sunlight, which are not so common nowadays, would not be useful. So in the health worker at the community, microscope will not be the best tool to use for a diagnosis. But then when it comes to health centers and hospitals, microscope and RP diagnostic tests are equally good contenders. And time for test completion, right? So the microscope usually requires more time compared to the rapid diagnostic test. That's why it's called the rapid diagnostic test. And in a setting where you have a low workload per health worker, that means you have not so many patients, you can use both microscopes and rapid diagnostic tests. But then if you're working in a setting where it's a place where there's a high workload and you have very low number of workers in the setting, microscope can be a little bit time consuming for you to actually offer services. So the choice would be the rapid diagnostic test. And again, this also goes again within the competence and training. Microscope needs a very highly skilled personnel compared to rapid diagnostic tests. So if you have workers that are limited in training, you'd rather use the rapid diagnostic tests. And if you have very specific trained people, and also you're able to do laboratory quality management that is functional, then you could use both. So this is like in a nutshell of rapid diagnostic tests and malaria, which microscopy tests which are useful when it comes to a clinical setting. But then when it comes to research level, that's when you use nucleic acid amplification tests. With microscopy, as I've previously mentioned, that it is very considered a field gold standard or field standard for this. And with expert microscopists, you can have as sensitive as 5 to 10 parsecs per microliter, but in most setting in the field, you will not be able to achieve that level of precision in daily routine. So you're looking at a limit of 100 parsecs per microliter. And you can get other advantages that we mentioned, and usually uses germ sustaining and oil emulsion microscopy at 1000x magnification. In the microscope, you have two major smears, so like a thick smear or a thin smear. We have a drop of blood and you stretch it out to the end so that you can have a monolayer of red blood cells for your analysis. And then you also have this thick smear here that can help you to have other diagnostic facilities. So you can see here, so for example, in this case, you have a thin smear, which is usually fixed in alcohol before staining so that it maintains the integrity of the red blood cells so that you're able to identify parasite species. Different parasite species can be identified by how they change the morphology of the red blood cells. So in our case, you could have the red blood cells here that are infected, and they have this signet rings, trophozoites, that can be counted as how much percent of the red blood cells that are infected in this context. This utility for this thin blood smear will help you to identify the species level. But when it comes to thick smears, these thick smear is where you can, these red blood cells will undergo hemolysis, and the ring stages or the parasite usually breaks free from the parasites, from the red blood cells, and you can count it against white blood cells. And the quantification is usually you count how many parasites you're seeing against up to 200 white blood cells when you have very high parasite density. When you have very low parasite density, you have to count at least 500 or 100 fields without parasites. And when you do this count, you usually convert it into parasites per microliter. And usually each microliter is estimated to have 8,000 white blood cells, meaning when you do a number of parasites counted against 200 or 500 white blood cells, is multiplied by a factor of 16 or 40, because this is 8,000. If you divide it by 200, you get 40. And whatever you counted, you could multiply by 40. You will have, if you counted by 200 blood VCs, you will get your factor of how many parasites you see per a microliter of blood. And this is an image of microscopy thick smear, where you could see classic headphone-like signet rings for the Plasmodium falciparum parasites here, and you can count them against the white blood cells. So in this case, you would have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 to 1, and then you go up until you finish 200 white blood cells. Right. So when it comes to quality control of the microscopy, it starts from the laboratory technicians themselves. How do you select the laboratory technicians? What kind of training do they have? And how do you assess them? And this usually affects the competency that they have. So you need to have a rigorous selection criteria, but also you have to do regular training and assessing them. And then this is going to, their competency, of course, is going to affect their performance. But things that affect the performance of them, they could be competent. But then if you have lack of supervision or cross-checking, and there is usually equipment and reagent issues, you don't have SOPs in the lab, all this will affect the performance of the rapid diagnostic, of the microscopy. And also when you have, don't have support or logistics networks where people can get back and forth and get some of the support as they go on, and also workplace environment severely affects this in case it's a high workload, as we previously discussed. Now back to the rapid diagnostics tests, which are immunochromatographic tests that are used for detecting parasites of specific antigens, especially coming from a finger blood sample. And this test detect only Plasmodium falciparum, but also there are some other tests that detect one or more of the other species in the human parasites, like Vivax, Malaria, or Valin. And these rapid tests can be in these lipsticks or cassettes or cards, and these are usually, cassettes and cards are usually used in difficult conditions, like in communities and where you go to village health workers are given, and they're relatively simple to perform and interpret and do not require electricity. But then quality assurance is the key in this context. When you want to select what rapid diagnostic test you want to use, for Plasmodium falciparum, especially in places where there's all transmission setting, you need to have at least 75% of your samples to be at 200 parasites microliter or more. So this is because of the detection limits that we've seen before, but also in the same when it comes to detection for Plasmodium vivax. And you should have false positive rate of less than 10%. And you should have invalid rate that should be, later of invalid results should be less than 5%. And there are several factors that affect your results, whether it comes to invalidity of false positivity or invalid results. And this is an example, this is a description of the mode of action of the antigen detecting malaria when it comes to diagnostic tests. So you have the bound antibodies, which is usually laid on the test, and then there's a lysing agent, which is labeled as antibodies of the parasites. So this is depending on whether you're going to use LDH or lactate dehydrogenase based ones, or you're going to use histidine-rich protein-based ones, or a combination of these. We're going to see them in a moment in the next slide. But then this is a test line that is bound with antibodies, and then there is a control line. So this is usually invisible control line here and test line here. And then once you have your parasites antigen that are captured by labeled antibodies, and then you put your buffer solution, and then it flushes all the way up to the end of the strip, you can get to see your captured antigen, which is labeled with antibody complex. And then this is a captured labeled antibodies, which could be only just for control. And these are different antigens that are used to detect these test lines, right? So you have HRP2, which is histidine-rich protein antigen. And this is usually specific for falciparum. And the only results you can get here is it tells you that there is no Plasmodium falciparum, or there is Plasmodium falciparum, or your results are invalid. Now, this is important because if you use another, it doesn't just tell you that there's no malaria at all, it just tells you that there's no Plasmodium falciparum. Then there's another type that it is histidine-rich proteins, and also it has aldolase, which is pan-specific. This one can tell you that there is no malaria if everything comes out negative, and if or it can tell you there's a plasmodium and falciparum or mixed infection, or it can tell you there's a plasmodium, vivax or vale or malaria without plasmodium falciparum, or it can tell you that it is invalid. Now, there's another type of rapid diagnostics test, which are histidine-rich protein based and lactate dehydrogenase based ones, LDH, which can tell you there's no malaria, or there is PF4 mixed, or can tell you that there is a mixed infection, or it is invalid. Again, so you can have either only purely LDH based, so LDH specific for falciparum and LDH for all the other species. This one can only tell you that there is no malaria or there's a mixed infection. It can't tell you if it is it's mixed within vivax, ovale, or malaria. And then there's another one which is vivax specific, LDH based, but vivax specific. This one is much more useful. It can tell you whether there's no malaria or there is falciparum or vivax or a mixed. It doesn't tell you about the other ones. And then there's other ones which is much more complex that can give you so many other options, whether there's no malaria or there is falciparum and or others, or falciparum and or ovale and malaria, or falciparum and or vivax and or others, or it could be invalid. Now you can see these can be very complex when it comes to manufacturing, and quality assurance is very, very important to make sure that the results are useful. And now these come with kits such as the buffer kits, the own materials, and it is important to make sure that you use the reagents that are given. This is an example here of a study where they assessed technicians who substituted different buffers from what they were before. So there's this, they all were given the same sample. So this one, slide number 1, is blood of a non-parasitized patient. So this person was given all the samples were given a blood that did not have parasites. So this one, the first one, they used the original buffer that came with the sample, but then others they used different samples, different materials. So for example, this one they used normal saline. This one they used tap water, and they used different options that gave you very different results. And it's not recommended to adhere to the SOP that is given to the rapid diagnostic test, because it has a tendency of giving you false results. And this is quite remarkable when people go to the field and are out of buffer solutions, or they have to look for other options and things like that. So this is something I wanted to share with you for you to take note of. And then when it comes to quality control, there's tools, they have to come from all the way from the manufacturer, right? So good manufacturing practices of the manufacturer are usually required, but then it's a bit tricky because they're designed to, they need to be designed to stay in a very hot environment, especially when it comes to transporting, and to stay long time before they expire, and then they need to be able to still be functional when they reach the end user. Now, most of the time, the countries that are affected with malaria are usually hot, and during transportation, maintaining a cold chain, especially for things like rapid diagnostic tests, might be challenging. So you might find yourself that you're finding challenges of quality when it comes to from the manufacturer. You might have a manufacturer produce them in a good way, but then during the transportation to the region or the country or the district, the quality is compromised. So there is a need to do lot testing or quality assurance to make sure that they are in the best way possible before they reach the end user, to make sure that you have less than at 5% of your false positives, and less than 10% of your false positives, and less than 5% of your invalid results. There are cases, I'm sure you can share, where you have brands that were very bad. We had issues like that in Tanzania with CareStat. So this is the last part for now, looking at an example of comparing how different diagnostic tools are used. This is the World Malaria Report, and this is a case of Uganda. You can see in how many patients were suspected malaria cases. We're talking about 27 million people were suspected malaria cases, but how many were actually tested, microscopy examined? We're looking at only 4 million out of this. And out of the ones that were microscopy examined, how many of them were positive? 1 million, right? So within the microscopy examined, out of the 27 million that were suspected, only 1 million came back microscopy positive within the context of the suspected cases in 2020. Now, if you look at the rapid diagnostic tests, they examined 22 million. And out of these, how many came positive? 12 million, right? So you can see the difference when it comes to ability to detect malaria. The rapid diagnostic tests have shown to be very much more useful in diagnosing or catching missed cases. The same case, you can look at all the numbers in also other countries. But then it doesn't come without fault. So it's quite important to take note that quality assurance is key when it comes to using rapid diagnostic tests. Right, so now we are to the treatment of the malaria. And if you remember correctly, we talked about two types of malaria. There's uncomplicated malaria and there is complicated malaria or severe malaria. Now, the clinical objective when it comes to uncomplicated malaria, is to eliminate the parasites from the body, that is to cure as rapidly as possible so that you can prevent progression to severe disease. So when you're having uncomplicated malaria, your goal is to eliminate the parasites, so to cure the disease. But then within the context of public health, if you remember, we talked about the two different definitions. Epidemiologically, your idea is to prevent onward transmission of the infection. So whether or not you want to necessarily cure, you just want to eliminate the parasites so that you don't continue with the spread of the disease or emergence of resistance and spread of the resistance to the anti-malaria drugs. So these are important things to take note when you're talking about uncomplicated malaria treatment. You need to avoid use of monotherapy, and you need to avoid incomplete dosing. And then you need to consider appropriate weight-based for artemisinin-based combination therapy. So since you're not using monotherapy, we're using artemisinin-based combination therapy. And also you should consider use of antipyretics because of fever of these patients. And also use of antiemetics, especially when patients are vomiting. So antiemetics can help your patient to be able to swallow. But it is important to note that some antiemetics can have a tendency to make a patient look drowsy. So it might confuse you with neurological manifestations. And also if the patient has one episode of seizure, you need to continue managing that and monitor that for progression of severe disease. And the artemisinin-based combination therapies that are available that you can treat with uncomplicated malaria for children and adults, including pregnant women, now within all the trimesters, methylomifantrin, amodiaquine, artesunate, amefloquine, diatrobicidin, piperacin, artesunate, sulfadoxine, pyrimethamine, and also there's a new one which is artesunate pyronaridine. And all these medications are useful when it comes to treatment of malaria, and they should all be used in combination. But depending on the zone that the country is and the level of resistance and things like that, these drugs are arranged differently when it comes to which one is the first line of treatment, which one is the second line of treatment, and which one comes after that. And this is important because you don't want to develop resistance for these medications. And they're usually given according to body weight. And for example, with artemether lumefantrine, it's given twice a day for 3 days. And this is the level for artemether. This is the milligrams for lumefantrine, according to the weight in kilograms. The same case you could find in here's for artesunate amodiaquine. Here is for the artesunate sulfadoxine pyrimethamine. Here is for artesunate mefloquine. But the difference between these two these drugs is with artemether lumefantrine, they're given twice a day for 3 days. Other drugs are usually given, the whole combination is once a day for the 3 days. And for artesunate SP is given single dose of SP on the first day, and then they're given artesunate ongoing once a day for 3 days. So this is sort of the combinations that you look at when it comes to drugs. But there's the hydroxystrobin and piperacin in younger children. The dose recommendation is if a child has less than 25 kilograms, is treated with, is supposed to receive at least a minimum of 2.5 milligrams per kilogram body weight per day of diatromycin and 20 milligrams per kilogram body weight per day of piperacin for 3 days. Now, sometimes you might treat a patient that comes back with recurrent falciparum malaria, and this can be a reinfection, or which is a new infection, or a recrudescence, which is treatment failure. It's the same infection that failed from treatment and came back. Now, treatment failure may result from either drug resistance or inadequate exposure of the drug to the parasites, which is suboptimal dosing. Sometimes the patient may have poor adherence. They have not finished the dosage, or they were vomiting when you're giving them drugs and you did not reintroduce the drug. So within 30 minutes after the initial vomit, the patient should be given back the medication again. Or there's unusual pharmacokinetics in the individual, or there's substandard medicines, right? So we'll also see this one in a moment. But then if the failure happens within 28 days, especially for most of the drugs, you consider that as treatment failure and go to the second line treatment, which is an alternative ACT that is known to be effective within your country or your region. But then if the failure happens after 28 days, usually is considered a new infection and can be treated with the first line ACT. But then there are things to remember within this context, that a new infection can be a new infection, but you can miss a recrudescence, especially if a person comes in a month after and then they are not asked whether or not they had prior malaria infection, or they were treated for malaria within the last 4 weeks. So most of the time recrudescences are missed, and this comes at a risk of developing resistance to these drugs, or missing out recrudescences that should have been caught. But then also for mefloquine, it's important to note that mefloquine used within 6 days of the first treatment is associated with an increased risk of neuropsychiatric reactions. So if the patient received mefloquine or a combination in the first 60 days or after 28 days, you should consider another alternative. And then within the uncomplicated malaria, also there's an objective of reducing the transmissibility of the treated patients with falciparum. As I've mentioned this to you before, of the gametocytes. So with treating gametocytes that are going to be picked up for ongoing transmission, primaquine is recommended as 0.25 milligrams per kilogram. But primaquine is known to cause hemolytic dose-dependent hemolysis. With higher dose of primaquine, some people can have hemolysis because of the deficiency of an enzyme known as G6PD, glucose 6-phosphatase dehydrogenase. And it was required before that you have to test people for G6PD deficiency before giving them primaquine. but now it is accepted to give it even without testing, except in pregnant women and infants that are aged 6 months or younger. And this is usually preferred, especially in low transmission areas, not any transmission area recommendation. Now, these are other special risk groups that are important to consider when they are at high risk of failure or because of the abnormal pharmacokinetics or because of drug-drug interactions or things like that. People who are large and obese adults. So large people who have just big body mass and they're not obese, they're usually given just a normal dose dependent on their weight for ACTs. But then if someone is obese, they have a tendency to have a volume of distribution which is larger and sequester a lot of the drugs in the fat tissue. So sometimes there is a controversy, an area of continued work to see what kind of dose would be actually appropriate for people who are obese and have malaria. And also in pregnant women and lactating women, it's important to consider that there's currently the new recommendations right now recommend to give all of them with ACTs irrespective of the trimester because they have no evidence of teratogenicity. And this is young children and infants. Young children and infants, especially the ones who are malnourished, they usually have a problem of being underdosed when it comes to the treatment. And still studies around these groups to see whether or not they're receiving the right dose amount is going to be also important. And then also people who are co-infected with HIV, especially when they're using Septrin or cotrimoxazole, it's good to avoid artesunate sulfadoxypyrimethamine because of the drug-drug interaction. And especially if also they're using efavirenz or zidovudin, it is not recommended to give them artesunate amodiaquine because of the drug interaction, which might cause either under exposure of the medication because of the metabolism. Also, patients with infection with tuberculosis, still the treatment would be the same, although there is potential infections, potential interaction with the drugs that are given for tuberculosis. For non-immune travelers, again, still irrespective of whether or not they were non-immune, ACTs are recommended to give for these patients. And also uncomplicated hyperparasitemia, patients that has high parasite rate, but they still have not uncomplicated malaria. They're recommended to treat them with ACTs, but also monitor them very close on the decline of the parasitemia. And in severe malaria, this is a medical emergency, and approximately 100% of the patients, if untreated, they die. And once you get them to treatment, you reduce the risk up to 10 to 20%. Also, we have to give supportive care. And the main objective in this case is to prevent the patient from dying. And the secondary objective is to prevent disability and prevention of potential recrudescence of the infection. So contrary to uncomplicated malaria, here your focus is make sure your patient does not die. And as a standard, adults and children receive intravenous or intramuscular artesunate, 2.5 milligrams per kilogram body weight on admission, at 0 hour, and then at 12 hours, and then at 24 hours, a minimum of 3 injections within 24 hours. This is to make sure that the artesunate has dealt with the big bulk of the parasitemia that you have there at first. And then once the patient has received at least 24-hour therapy, and they now can able to eat and tolerate oral therapy, you can complete your treatment. You should actually complete your treatment with 3 days of an ACT. So you can't just do injection artesunates and stop there. You have to complete the treatment. One thing to note is that children who are younger, less than 20 kilograms, with severe malaria, they need to get a higher dose of artesunates, up to 3 milligrams per kilogram body weight per dose. You can do it for 2.5 milligrams, 2.4 milligrams. And this is just as I've discussed before, when it comes to severe malaria, you have many other complications like coma, hyperpyrexia, convulsions, hypoglycemia, severe anemia, acute pulmonary edema, acute kidney injuries, spontaneous bleedings, metabolic acidosis, and shock. All these need to also be managed appropriately in such a way that these patients are able to survive. So things like maintaining the airway in cerebral malaria and trying to find other ways, other causes of seizures, if there's any. Make sure they get sponging, cooling, or they get paracetamol, especially when they have high fever. Convulsions, make sure you maintain their airways, check the blood glucose, which has also tendency to malaria has a tendency to lower blood glucose, and then make sure that you check that. Severe anemia, look to transfuse them with fresh blood, fresh whole blood, because these are patients who have lost a lot of blood. Within acute pulmonary edema, the lungs are swollen with water, so you have to make sure they prop their beds up. They're at 45 degrees, and then provide them with oxygen and diuretics to make sure they're losing the water. But then also you need to make sure you exclude pre-renal causes, right? And especially when they have acute kidney injuries, because this is going to affect how you do your management, especially when it comes to hemofiltration or hemodialysis. Also look into other issues related to shock and metabolic acidosis. And consider referring patients to health facilities where they can get better care after giving at least first dose of artesunate. If you're in a referral place, a remote place where patients cannot get this kind of care that I've just previously described to you. So, and there's a protocol around pre-referral cares where you have to make sure the patient gets at least one dose, because sometimes it might take time before they get to the referral facility, and they get the fever at least managed. Right, so then we're going to get into the second part of this presentation, which is monitoring the efficacy and safety of the anti-malarial drugs and drug resistance, right? So all malaria programs should regularly monitor the therapeutic efficacy of these anti-malarial drugs by using standard WHO protocols like routine surveillance, therapeutic efficacy studies, resistance monitoring, and pharmacovigilance. So when it comes to routine surveillance, there's an initiative known as Test, Track, Treat. And this is where every suspected malaria case is tested, every confirmed case is treated with quality assured antimalarial medicine, and also every disease is tracked timely and accurately with surveillance system. This can go all the ways to things like home visits and things like that. This is a conversation you have when it comes to surveillance. And when it comes to therapeutic, I mentioned here, there's a therapeutic efficacy studies. These are going to be very important studies when where they're done usually every 2 years to check that the drug is still, artemisinin-based combination therapy are still efficacious. And this is a workflow of how decisions are made within the results of the therapeutic efficacy. So you take your patients, you treat them, and then you look at how many of them by day 3 they are still parasitemic. They come for a follow-up for 28 days or 42 days, depending on the half-life of the medication. So the percentage of patients parasitemic at day 3 is going to determine what you do. So if it is less than 10% of your patients are parasitemic on day 3, then that is not a very bad sign. It means your efficacy of the drug is more than 90%. Then you can continue following them up until day 28. By day 28, if still less than 10% are parasitemic, then you have no evidence of resistance to artemisinin, and the partner drug is also effective. So then you don't have to change any policy. But then if by day 28 or day 42, you have more than 10% of your patients are parasitemic, which means you need to make sure these patients came back with recurrent parasitemia, and it is usually corrected with PCR to make sure that this is either recrudescence or new infection. Then, if there is no evidence of resistance to artemisinin, in this case, because resistance to artemisinin will be indicative in your first 3 days. Artemisinins are responsible for your first 3 days clearance because the half-life is very low. But then this will tell you that your partner drug is failing. So if you have artemethyl or mefantrin and more than 10% of the patients come back with parasites, then you need to change your ACT because the partner drug is the one that is defunct. But then if at day 3, both, you have less than 10%, more than 10% of your parasites are parasitemic, or less than 10%, but it is increasing over time. And then by day 28 or day 42, none of these people are sick anymore. Then you suspect artemisinin resistance because your partner drug is effective, because the partner drug is responsible to clearing the remainder part of the disease. And then you confirm resistance to artemisinin. How do you confirm resistance to artemisinin? Also by checking whether there are any molecular markers for artemisinin. I will talk about them in a minute. But then you don't need to make any change of policy requirement in this context. But then if you have this case at more than 10% in day 3, more than 10% in day 28, you are suspecting all the drugs are failing. And then you need to confirm artemisinin resistance and then change the medication, which is a non-ACT option, looks at the chloroquine or other drugs. And this is just a similar chart talking about the types of responses to therapy that are monitored during a therapeutic efficacy study. Someone might have adequate response if they don't have parasitemia in 2028, or they have no any other signs, danger signs. The early treatment failure if they have danger signs of malaria day 1 to 3, or parasitemia on day 2 is more than on day 0, or there's continued parasitemia on day 3 with fever, or parasitemia on day 3 more than 25% count on day 0. And then it's late clinical failure when someone comes back with, after 3 days of parasitemia, comes back with fever and parasitemia. It is late parasitological failure when between days 7 and day 28, someone comes back with parasitemia, or with parasitemia and axillary temperature of less than 37, which is no fever. This is just a parasitological failure. There's no fever. Right, now talking about another interesting part, which is resistance. Artemisinin resistance is phenotypically characterized by delay in parasite clearance time following ACT. This is just as I've just described in a moment here. So, and it's usually associated with the polymorphism in the propeller gene of KL13 gene or K13 gene. There's evidence that's ongoing right now that this is independently rising mutations of concern in Africa. It has already been reported that there's artemisinin resistance, or it's called partial resistance, because it is only just delay of parasite clearance time when it comes to artemisinin. Eventually they get cleared, but it's delay with less than 3 days. This partial resistance has now been reported in some places in Africa, like this study in Uganda. They've just identified this study, and then there's another one in Rwanda. Also, they've reported mutations of concern, genotypes of concern when it comes to K13 mutation, which are also associated with delayed parasite clearance. Now, what should we do then when it comes to quality of anti-malaria drugs? Because sometimes there's resistance, can be actual resistance or delay in clearance, or it could just be poor quality of the medicines. And these medicines could be falsified or counterfeit medicine, which when you're talking about poor quality medicine, they could be falsified or it could be just substandard. Falsified, this is someone on purpose makes medicine that either have little or no active ingredient, or sometimes even harmful ingredients. But then when we're talking about substandard medication, this is where a legitimate producer produces incorrect amount of active drugs. And the key word here is legitimate. This is legal. This other one is illegal. It could be maybe do poor infrastructure or something wrong in the batch, or it took long until it has degraded, because, for example, artemisinin themselves are inherently unstable, so it's very difficult to make them stable along the way. And identifying counterfeit drug versus substandard drugs might be very difficult to distinguish them at the point of care. So this is another context that is important to take note of. So national drug authorities should ensure that the antimalarial medicines are provided, both public and private sector, are of acceptable quality through regulations, inspection, and also law enforcement. This is an example of a study that was in Kenya that showed a market share of ACTs by WHO pre-qualification status. So there are manufacturers who are pre-qualified by the WHO when it comes to manufacturing these ICTs. And you can see from end of 2017, the WHO pre-qualified medications actually had the biggest share of the market. But as time goes by, the share of WHO pre-qualified medication is shrinking. Now, this increase in the ACTs that are not WHO pre-qualified is risky, because it doesn't necessarily mean that these medications are substandard or they are counterfeit. It's just that they are of unknown quality, right? So this is difficult to make sure that you're controlling the quality of the medication, especially when it comes to resistance and it comes to proper medications and things like that, right? So there are challenges when it comes to malaria case management, especially within involvement of different stakeholders. Having an increased number of unknown quality of ACTs, continued presumptive diagnosis, and this is a very interesting challenge, because sometimes a patient might be tested with a rapid diagnostic tests, and the tests come back negative, and the doctors, because of lack of integrated management control, they have little to decide about what other cause of fever, because of the facility doesn't have other tests to test other fever. So they continue to test, treat for malaria despite having negative results. But also there's a C-load or versus systematic approach. This is what I was mentioning just now, that sometimes you would have a child coming in with other causes of fever, but there is no proper management system when it comes to alternative tests for other diseases, but also when it comes to training. Like right now we're getting training on malaria, and it's focused on only malaria. So this is a siloed approach when it comes to malaria case management, but it needs to be much more systematic approach. Even goes into referral systems, right? Referral systems to, if a hospital comes in and someone gets tested negative for malaria, they need to refer them to other facility, and that might come out as referring their clients to other places instead of treating them there, and that's a loss of money or income within that test for them. So there is a need to have a systematic approach to these diseases. Another challenge would be things like ACT and RDT financing constraints. These are especially within the framework of most of the funding that comes for malaria treatment. Malaria generally is quite broad standing, right? There is vector control, there is a mosquito control, there is so many things that are going on, needs to be there. And focus can be shifted in many other places, that financing for rapid diagnostic tests and ACT is marginal, even more marginal to support for, let's say, private sector. So this is another challenge that is available. And then there's also data availability and quality. These are some of the problems that to know what kind of data, whether the valid and things like that. The quality of data is quite another big problem when it comes to malaria case management and designing interventions that will involve both the private sector and the public sector in malaria care. And opportunities that we need to have, for example, in Tanzania, they're using accredited drug dispensers entities, ADOs, and this helps to improve the motivations for these drug dispensers or pharmacies to stock in much more useful and safe drugs, because they can get also linkages to the accredited dispensers or suppliers. But also we should start thinking about manufacturing locally within the African continent, or even in East Africa region, because COVID has shown us that this disrupted a lot of things when it comes to supplies chains and things like that. And this is an opportunity for us to start considering regional manufacturing. It might have a problem, the financing of it, but it's an opportunity to look into. But also the need to integrate with universal health coverage agenda in terms of the financing of the hospitals as a whole, rather than just silo operations. And also looking at digital tools to improve on data collection when it comes to, I think I know some places they use MSDQ, that look at the data real-time, digital tools for data monitoring when it comes to therapeutic efficacy, when it comes to day-to-day functioning for both private sector and public sector. Also the financing mechanism when it comes to paying vendors and things like there's mobile money and issues related to that could be used within that context. All right, so as a whole, we've generally discussed so many things about malaria case management. We've discussed issues related to malaria case definition. We've discussed issues related to malaria diagnosis, issues related to malaria treatment. We've touched through challenges associated with the drug resistance and other issues associated with the management. But now there's this literature here, which I'm going to leave with you as an assignment. It's going to be in your notes to find it. That identify progress that is remaining and the challenges that come when integrating private sector when it comes to malaria case management. Now, based on your experience in malaria case management system within your country, I'd like you to write me a short essay to identify 3 takeaways from this article that you're going to read that can be immediately integrated or is being immediately integrated within your country. Thank you very much, and we'll be taking any questions. These are your references. And thank you very much.